emergency care, the Plymouth course, some people might know it as, up in the Royal, Liverpool. So if any of you have any questions about that as well, you can always give me a message on Facebook. This is my first session ever teaching on Zoom, so just bear with if we have any technical difficulties. And I've also got another screen up for the chat, so I do have access to it, but if I'm looking away, it's to check the chat, okay? So this is the first cardiology revision session for finals. I'm also doing another one, I think a week today, so let me know in the feedback forms if there's anything in particular you want me to do different, or include, not include, things you did like, because that's really useful for future teaching sessions. So yeah, we'll begin. So today's session, we're going to be covering ACS. So that's going to include myocardial infarctions, both your NSTEMIs and then your STEMIs, and then your unstable angina. I'm happy to share these slides afterwards as well. I've made them and then referenced everything at the bottom as well. So if you would like a copy of them, just give us a message. I'm sure we can share them, or I can pop them on the event, something like that. So to start, wait, get the screen to go. So first things, you probably all know this already, but ACS is an umbrella term. So you're never going to meet anyone in the hospital that's diagnosed with ACS. It's going to be split into either a STEMI, an NSTEMI, or unstable angina, and they're all fall under ACS, which just describes ischemic heart diseases. These three diseases all have the same risk factors, and we'll divide them into modifiable and non-modifiable. So when it comes to like finals questions, you'll probably get some hints from the stem of the question. So it could be a male, it could be an older male, sort of with the increasing age, or they could include something like he's diabetic or a smoker, and there's little subtle hints that they'll include the risk factors in potentially, and that should sort of get the cogs turning and thinking, right, is his risk factors pushed up a little bit more? So yeah, they're good to know, the risk factors. So the way we classify ACS is either as an unstable angina or a myocardial infarction, and then they're classified based on either both the ECG changes, so are there any present, and then what biomarkers have been shown in blood tests. So your STEMI, which is your ST elevation myocardial infarction, is the presence of ECG changes showing that ST elevation, and then positive cardiac biomarkers. So most of the time that will be troponin. So I'm just going to refer to it as troponin for this teaching session. I don't know if some of the hospitals might not use that, but where we are, everyone seems to use troponin. And then your NSTEMI is your non-ST elevation MI. So they're still having an MI, but you don't get the ST elevation. You can have no ECG changes, or sometimes there are subtle ones, but there's that, the ST elevation is not present, and then you'll still have those positive troponin rise. And then the final one is your unstable angina. That's when you don't have any changes to your biomarkers. So your troponin will come back normal, and then you've got normal ECG. There's no changes. There's always a few anomalies, but that's the general rules when it comes to classifying the ACS, ischemic heart diseases. And then you can also look at the pathophysiology. So with your unstable angina, you'll have a partial occlusion of a coronary vessel that will lead to your decreased blood supply at that time, causing the pain. So then that is your ischemic symptoms. But then when you go to do the ECG on them, they haven't had any of the changes that's resulted in the sort of ST elevation or reciprocal ST depression, things like that. Your NSTEMI is a partial obstruction of a coronary artery. So it could also be described as a partial occlusion. And then that affects the inner layer of the heart. So it's not the full thickness. And that's why you don't get the ST elevation. So you've got the decreased blood flow to the heart, and there is a mismatch between the supply and the demand that the heart muscle needs. So the myocardial ischemia then gives you the chest pain, the other symptoms of the sweating, things like that. And then you can also lead to the positive biomarkers. And then your STEMI is a complete occlusion. So you have the complete full thickness myocardial ischemia. So I've got a diagram on the next thing. I've put a little bit of notes there about the plaques, and it's stuff we all covered in second year, so I'm not going to go into too much detail because this session could go on and on, but as I said, slides are available afterwards if you'd like them. So I thought this was a really useful diagram. So it just shows like the difference between your stable angina, we're not covering that today, but how NSTEMIs and STEMIs, really they're the big things. So I'm not sure if you can see my mouse or not, but when you talk about the transmural infarct, so the full thickness infarct, which leads to that ST elevation, whereas the NSTEMI, you can have the normal ECG or the inverted T waves here, or ST depression. So if we're following the isometric line, then the ST is depressed. And then you've got your unstable angina. So I thought this is a useful photo for reference. It's available from Google Images, or top 5 photos come up. This was more for completeness. I think you'd be unlucky if you got a final questions on this, but there are different types of myocardial infarction, so I just included this for sort of overall completeness. The most common MI you see is a type 1 MI, so that's the classic pathophysiology. You've got a plaque that's atherosclerotic, it's disrupted, and that leads to your myocardial infarction and the cutting off the blood supply to the heart muscle. But then you also have these other sort of rarer types. So you can have it where they're septic and there's a mismatch in supply and demand, or a type 3 is where you haven't yet had any of the blood results back, so you can't confirm what's fully gone on. And then the 4 and 5 are related to sort of interventions we've done in the hospital setting that's then led to the infarct. But not going to dwell much on this, you can refer back to these slides. So our clinical features, I'm sure a lot of you know this already. So it's an acute onset. Classically, it's retrosternal chest pain, dull squeezing, sometimes described as a pressure light or a tightness of the chest. Sort of the classic phrases as like an elephant on my chest, or you'll have the patient sort of holding their chest, be like, it's really pressing down. And then you get your radiation either to the left, down the arm, up to the neck, into the jaw, and sometimes it could even be sort of epigastric. And then you also get these autonomic symptoms associated, so the nausea and the vomiting. They can be sweaty, they can appear really anxious, even agitated, and they could even be lightheaded, fainting, feel a little bit dizzy, a bit out of it. Keep going. And then this is just a question if people want to pop in the chat what they think, which group of patients are more likely to present in an atypical fashion with MIs. So this could be like they're sat in the department with very, very little chest pain when in fact they're having, if you are then handed an ECG with widespread ST elevation. Do we know what groups? Yeah, perfect. You've got all 3 there. So the elderly, the diabetics is the classic one, and also women are more likely to have atypical presentation than men. So then when it comes down to our investigations, kind of covered this already. So the big things we want to exclude ACS or to prove which form of ACS the patient is having is an ECG and our cardiac troponins. So that's another breakdown of sort of, it's a repeated diagram. So we're going to expect unstable angina, they've got their normal ECG, there's no ST elevation, and when we get our blood results back from the lab, there is no rise in that cardiac troponin. Our NSTEMI, we've definitely not got any ST elevation anywhere on that ECG. It could be normal, we could have some ST depression without any ST elevation elsewhere, or we could have some T-wave inversion. And then once we get our blood results back, they will have that rise in the troponin. And then the STEMI is either ST elevation with potentially reciprocal changes of ST depression. And then a new left bundle branch block is also diagnostic of a STEMI. And then once our bloods come back, they'll have a rise in the troponin. So just put this slide in. This is just to remember the differentials. So when we do have those patients with chest pain, there's also a wide range of causes that could cause that pain that isn't even related to the heart. So you've got to think about either the stuff that is going in the heart that isn't ACS. So you've got your myocarditis or your pericarditis. So you think, have they had a recent viral infections? Any other clues going on? Are they a lot younger? So sort of someone in the early 20s, 30s, they probably wouldn't be having ACS, but are far more at risk of something like pericarditis. And then we've got our non-cardiac causes. So remember what else is nearby. We've got GI tract, and then the lungs as well can give us referred sort of central cardiac chest pain. And then there's some differentiations of the way patients could potentially describe their symptoms. So yeah, I'll just give you a second to read those through. They're really useful as like buzzwords for exams. Anyone got any questions so far? Okay, keep going. So the general principles when it comes down to ACS treatment is when we've got a patient, so I'm based in the A&E for this year, so this is quite A&E heavy, but when we've got a patient in the department with chest pain, we want to make sure, are they having a heart attack? And have we got the sort of things in place to make sure that we're going to be treating that heart attack? And if they're not, we've ruled that out, okay? So if someone's got chest pain, you've always got to consider, are they going to be having a PCI? Is the ECG going to be coming back with ST elevation, and we're going to be needing to transfer them to sort of heart and chest round here? And then, so you've got to bear in mind, revascularization is a potential for all those patients with chest pain. What monitoring are we going to be doing for them? So we need an ECG and then potentially subsequent ECGs. We could potentially going to be putting them on continuous cardiac monitoring, and then we're going to need a series of troponins. So we'll get one as soon as they come into the department, which gives us either the baseline, or we can compare to previous results. And then we're going to look for trends. Is it rising? Is it falling? Is it staying the same? And where that fits within like the normal acceptable ranges. We're going to get IV access on these patients. That's important for the treatment, what we're going to offer them. And then they're presenting with chest pain, so we're going to want to give them something to treat that pain. Okay. So the generic ACS treatment, which I'm sure you've all heard of, is Mona. I've always remembered it as Moana, adding in the extra A. So, and then I've just included the doses, which are quite useful for when you're sort of being quizzed on the wards, and that little bit of extra detail always sounds really good. So morphine, you want to give that IV. That's why you've got your IV access ready. You're going to give a starting dose of 2.5 to 5 milligrams. But then if you've got those tiny little old ladies who are really slim and really little, you're going to potentially lower that dose. Oxygen isn't necessary for all patients. The British Thoracic Society has said that patients should only be given oxygen if their SATs are dropping below 94%. So just remember that one. If you've got a blurb with a patient sort of present with chest pain and their heart rate, blood pressure, blah, 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 and their SATs are sitting at 98%, oxygen wouldn't be part of the treatment for them. Aspirin, you're going to give them a high dose aspirin. So the standard dose, if you hear of people being like on long-term aspirin is 75 milligrams. So this is a lot higher. Most of the time when patients have come into A&E and they've been brought in by an ambulance, the paramedics will have already given them some aspirin, but that's something if they're self-presenting, things like that, everyone receives aspirin unless contraindicated. And then nitrates, so it's GTN spray, most commonly the spray, but you can give it IV, and there's other options, sort of other nitrates available. And then we're going to give them an anti-sickness, so metoclopramide 10 milligrams IV. Yeah. Oh, sorry. Just two extra notes. So the nitrates can cause hypotension. So if you've got someone with a dropping blood pressure, you would avoid nitrates. And when you're choosing your antiemetic, Cyclizine is avoided in patients with chest pain as it can speed up the heart rate, causing more ischemia. So always go for metoclopramide. Or another one, just avoid the cyclizine. And then this is just a few ECG hacks I've learnt whilst on placement. So T-wave inversion can be normal. So don't worry when you hear that someone says, oh gosh, they've got T-wave inversion in AVR. That's okay. That's not to worry. And then also lead 3 can have a normal variant of T-wave inversion. So if you've got the possibility to pull up old ECGs, make sure you do that, and you could spot that that is actually something they've had for 10 years. With the way some people present at hospital, they can have a series of ECGs, and they're really, really useful for comparing to. And then look for reciprocal changes. So when you've got that ECG in front of you and you can see an ST elevation in V2 and V3, you're going to look to the other side of the ECG and have they got ST depression in, say, leads 2, 3 or AVF, and that supports the idea that the patient is having a STEMI if you have those reciprocal changes. And then look for left bundle branch block as well. And then with that, you also want to compare to old ECGs, because a new left bundle branch block would mean that they're having a STEMI, or they have had a STEMI at some point between the last ECG and the one that you've got currently. That produces a T-wave inversion in the lateral leads. So your V5, V6, AVL. So T-waves should be positive. That's why a negative or an inverted one is seen as abnormal, unless it's AVR or lead 3. And then I just include this diagram, so you're looking at this one here, because for those that find ECGs very overwhelming, this is a lovely laid out one that I think is really useful when it comes back to revision. And it represents ventricular repolarization. So left bundle branch block, I thought this was a really useful diagram. So it just shows you your left bundle branch block when you're looking at it on an ECG. It's this widening here. It's really obvious to spot once you know what you're looking for. And it's the William and Marrow revision, but I always found that really confusing, and you get, but yeah, this is what you look for. And then when we put it up to an actual ECG, you can see this widened here. It's just getting used to seeing lots of ECGs. Always when you see ECGs on the ward, or even patients on not in A&E and other wards, and they've got ECGs printed out, just take it and have a little look, because you'll start, like, the more you look at, the more you'll pick up the subtle things and sort of get the doctors to quiz you, like, what do you think's going on? It's really helpful. So localizing the infarct, I'm sure a lot of you have seen this lovely diagram. It's very, very useful. It's one of those things you've just got to learn, and it's all about patterns. So you've got your anteriors, your laterals in the purple, and then your inferiors and your posteriors. And then you can, depending on which leads are, you can take a good guess at which vessel is then involved. I'm not going to read this off to you, that's really boring. And I'm not sure, we're already at 25 past, so I'm not going to make this session drag on. But yeah, take another look at this, and when it comes to revision, just get your head around which leads affect which vessel is affected. So yeah, so I thought we'd play a bit of spot the ECG changes and where we think the STEMI is. So if anyone wants to put on the chat, where is the ST elevation, and then what type of infarct? Or I can go back to the other diagram for a second or two if people want, just let me know. No? No one writes anything. This is going to be really boring for like 10 minutes. Yeah, perfect. anterior. So highlighted them there. So we've got this ST elevation in V1, V2, V3, V4, V5, and then we've got this reciprocal ST depression in lead 3 here. So if you're looking at the isoelectric line, can you see my mouse?
Yeah.
Yes.
Yeah, fab. So if you, oh gosh, it's gone. So if you keep going along this line, you can see that the ST depression, like that. All these ECGs are from Life in the Fast Lane. They're really good resource when looking, and they give a full explanation underneath sort of what's happening where. So next one. Or just describe what you see in any leads. You don't have to say where it is or what's exactly going on. Where's the abnormality even? So someone said inferior. ST depression, yeah. Where is that ST depression? Fab, so you got it. Someone said posterior, yeah. So you've got your ST depression in V2 and V3, and then there's these T waves here. So this is the same patient, and when we see these changes doing a standard ECG, you can actually place some at the wires of V123 onto their back, and then you get an ST elevation being shown. So that's how to confirm it's a posterior. And does that make sense? Have you all heard that before? So that's what it means when people say look at V789, it's placing the ECG stickers onto the patient's backs and then redoing the ECG. Okay, so yeah, there's those changes. What does anyone see? Okay, so yeah, it's an inferior. So it's 2, 3, AVF. Let's go. So I've done the green boxes. Sorry, I don't know if you see these are green. So that's the reciprocal changes. Yeah, we've got an anti-receptor one. There's that ST elevation. And then this is the final one. This might not be something you've heard of, or it's something you might have come across when reading around sort of ECGs. This is, anyone know what this is? So this is, it's not pericarditis, it's known as tombstoning. So all of these are described as tombstones, and it basically is the patient is they're having an MI and they're very, very, very sick. So they're very, very interesting ECGs to look at, but big sick if you see this, or if you hear of anyone describing tombstoning on an ECG, this is what they mean. It's this sort of curved, like looks like graves in a graveyard. So this is just for completeness. I don't think they'd ask this in finals, but your ECGs will evolve over time if you're having a STEMI. So the first thing you will notice, it could be before the ST elevation has even evolved, is you can have hyperacute T waves. These are different to peaked T waves, or like tall tented T waves associated with hyperkalemia. They're these large wide T waves here. So I've just included this photo which shows the two next to each other. And then in sort of the hours after the infarct, you'll get this ST elevation. And then you have what's called Q waves developing, and then this deep T wave inversion. This is just something to be aware of. I don't think they'd ask this for a finals question. That'd be really, really harsh. But yes, just to refer back to, again, take a screenshot of this if you fancy, or you can get the PowerPoint slides afterwards. Yeah. And then these are just some more photos of how they evolve. So this is quite a good one. So you could take an ECG of a patient every day, and it would look slightly different following a STEMI as your heart sort of recovers. And it can, in fact, normalize or even have some. Yeah. Okay, so troponins, which is our other useful investigation. We want to take that as soon as the person arrives, and then it's also really good if people have had previous troponins to refer back to, because a rise in troponin doesn't just mean that they're having a heart attack. It can be other things causing that. I've not included that for here, but just so you're aware of. And then depending on where you are and what troponins used by that hospital and what guidance you follow, you'll tend to take a repeat troponin, usually like 3 to 6 hours, but it's really variable. And then another note is you'd also take repeats of ECGs if their symptoms changed at all, or and you'd repeat a troponin if you saw a change in their ECG, if that makes sense. And then if people's troponins are dynamic, so they either go up or down, or they start low and high, and then they're going to go for PCI, even if it was an NSTEMI. So this is just a screenshot. I found this online. This is not what's used in any of, it's not a Liverpool hospital, but it basically shows you what you do with your troponins. So there's the way hospitals use it, they'll have thresholds, and they'll have like a normal value and an acceptable one. So that's our green section here. And we're able to rule out a yellow section where you've got a rise in a troponin, but we're not quite sure what's happening. So we want that repeat one, and that will give us a better indication of what's going on. Do not need to know this, but this is just to have an awareness of how we use troponins in the hospitals. And then if it's really high, you know that they're having ACS straight away. You don't need to rely on that second one. But yeah, this was from a hospital down south. You can Google like ACS troponin pathways, and this is all available. And then there's other biomarkers. This, I've taken this from notes I've made in a lecture in second year. The most common one is troponin, but you can also use creatinine kinase or myoglobin. These are far less commonly used. And then people's CRPs can go up, people's white cells can go up, and then you can also look at like BNPs as well if they've got a bit of heart failure. But yeah, you can read that. Future dates. I'm conscious of time already. Fab. So, STEMI management. So, we've already gone through that you wouldn't give anyone oxygen unless their SATs are below 94%. You would give them GTN, sublingual first line usually. So they might have had that in the ambulance, they might have had angina and already taken that whilst at home, and their chest pain is still present, and they're taking their GTN. And then when they get to either the ambulance crew or into the hospital, we would give them some morphine and some metoclopramide. We give them their aspirin, this high dose 300 milligrams, and then we'll give them a second antiplatelet. So it's usually ticagrelor, but it could be clopidogrel or prasugrel. That one's not commonly used. And they are P2Y12 adenosine diphosphate receptors. antagonists. That's like extra detail. I definitely didn't know that for finals. And then for a STEMI, they're going to be going to the cath lab for primary PCI, and we're going to aim for that within 90 minutes. So the way it works in Liverpool, all the patients shouldn't ideally come to any other A&E. If they've got a STEMI, they go straight to Broad Green, Lower Liverpool Heart and Chest. So we don't see many in the Royal. It's if they present themselves rather than the ambulance would take them straight there. There's a pathway in place. And then our NSTEMIs, we would look for the ECG changes. If it was normal and then the biomarkers come back as raised, we're thinking, okay, we've got an NSTEMI going on. And with that, we would then risk stratify the patient there in front of us using, does anyone know any scores we can give patients? Yeah, Grace, that's it. Sorry, I just saw that other question, Katie. Who's rotating that GTN no leave to repeat it? She's not telling actually. I presume you try an alternative one, but I'm not sure. I can look that up for you. I can ask someone tomorrow on placement. I'm sorry. So the risk is dependent on GRACE score. So GRACE is a score and a percentage, and we'll go through that in a couple of slides time. And then we also look at the patient, so how they are in front of us. So a patient would be deemed very high risk if they have signs of hemodynamic instability, their blood pressure is falling, things like that. If they're in cardiac arrest, so their ECG hadn't shown there's a massive STEMI going on, but then all of a sudden they've really deteriorated and are in an arrest. If they have life-threatening arrhythmia, or there are any weird sort of non-classic fitting ECG changes, we want to revascularize them, ideally. So that means with PCI, so we would get them over to heart and chest for the primary PCI, the same way that we would with our STEMIs. And then our high risk patients are the ones that TROPs are changing. So, and their GRACE score is coming up as more than 140. We want to ideally intervene with them, not within the 90 minutes, not within 2 hours, but ideally within the next 24 hours. So they need something happening pretty soon, okay. And then our intermediate risk patients are sort of the ones with the diabetes. They might have some renal insufficiency, they might have some heart failure going on, and they might have already been under cardiology. They've had some previous heart surgery, maybe a cabbage or some other forms of stenting. So there's obviously some sort of disease going in with the heart. So we'd want to make sure that they'd get at least a coronary angiography. So again, we'd probably end up transferring them over to Broad Green, or we could do it in the Royal, I think. But the hospital might be able to do that themselves. But again, they need some sort of intervention within the next couple of days. And then the low patients don't have any of the above. They're usually fit, well, healthy ones, and they've not got recurring symptoms, and they've not got any of the other sort of diabetes, renal stuff. They've not had previous stents, and their GRACE score has come out as low as well. So I'm just going to skip this one. So we don't use GRACE with a STEMI, we only use GRACE with an NSTEMI. And then if a patient's considered high risk, we send them for angiography, as I said. And then the lower patients, so all patients with an NSTEMI at some point will have an angiography. It's just how high risk will determine how quickly we'll do that for them. So GRACE scoring is made up of your age, your heart rate currently, your blood pressure at the time. It looks at your renal function if you have any form of heart failure, if there's been any sort of ECG changes, whether you're in cardiac arrest or not, and then your biomarkers. And it's a web-based model, so you can sort of log on the computer, MD Calc, and it gives you the form to fill out with all your patient's sort of details, age, things like that. And then this was taken from Pulse Notes, I think. So GRACE guides our 6-month mortality risk. So the higher the score, the higher the risk that they would die within the next 6 months. So determines how urgently we need to intervene, as I've said. So the high risk ones would have an angiography within 72 hours, and we'd probably end up stenting them. They'd have some antiplatelet therapy given, so potentially lifelong aspirin with clopidogrel, and then an extra glycoprotein. That's for nasty, you don't need. That's more if the chest pain continues. That's not given to everyone. And then our low risk would have the dual antiplatelet therapy, lifelong aspirin and clopidogrel. And then the really, really low risk would have aspirin. This is at lower dose. This would not be 300 milligrams of aspirin. This would be the 75 milligrams. So this is an MD Calc screenshot. I've made these figures up. So we could have a 66-year-old male who's sat in the A&E department. His heart rate's 87. His blood pressure is 125 over 90. And his creatinines come back 100, which is normal. He wasn't in cardiac arrest at admission. He's not got any ST changes on his ECG, and he's got some abnormal enzymes. So we're thinking, yep, he's got an NSTEMI. His KILIP class, that looks at if they've got any heart failure symptoms, and that forms part of the GRACE criteria. So this guy didn't have any. He didn't have any edema. He didn't have like JVP, anything like that. So his score would be a 5% probability of death from admission in 6 months' time, and he would score 106 points. So you would never need to know this. This would be something you do in the department, like popping the numbers in and sort of acting on the results. And that's what we do. That was again a Pulse Notes diagram. Cannot take any credit for that. And then that's just another overview, slightly repeated. So it's again following the same generic, starting oxygen if they're hypoxic, nitrates if their GTN isn't effective. That's Katie's question before. Yeah, so some NSTEMI patients would go for PCI within 24 hours, yeah. Or at least they'd have a coronary angiography, and then they would potentially stent them then to try and prevent any NSTEMIs going into STEMIs, is my understanding. And these NSTEMI patients would receive heparin or low molecular weight heparin to reduce the clots forming and reduce the chances of an NSTEMI becoming a STEMI. So if you remember the diagrams in the first couple of slides, it showed like the partial occlusion versus the full occlusion. So you want to keep the blood thin to stop that occlusion, the risk of a thrombus going and fully clotting off the arteries. So yeah. And then just a quick overview of myocardial infarction, secondary prevention. So I've kind of covered this already, the dual antiplatelet therapy. And then patients, once they've had an MI, would be started on an ACE inhibitor, a beta blocker, and then a higher dose of a statin. And then we would also advise them about their diet and their exercise and when they can start having sex again. And you can read lots about diet and healthy fish oils, Mediterranean diet. There's lots out there. That's a bit more reading. I'm not going to read that out to you. Depending which hospital you're in, they'll all use different things. So some places will use clopidogrel over ticagrelor, and some will use one over the other. And I wouldn't get down to don't get fixated on things like that. Yeah. And then I just wanted to go through complications of myocardial infarctions. So this is a list of the ones that could occur. These can happen anything from sort of minutes to hours afterwards to days to weeks. So you've got your cardiac arrest, cardiogenic shock, chronic heart failure, you've got your arrhythmias, pericarditis, left ventricular free wall rupture. You can get a defect, a VSD, acute mitral regurg, or ischemia of the papillary muscles. I'm not going to go into depth of all of these. PASSMED's really good for like the buzzwords of these. What I've done is made a timeline of when these could happen. So once you can, you'll find when you do questions, it will give you sort of, this gentleman had a heart attack 2 weeks ago. He's now suffering X, Y, and Z. So the time that these that's elapsed between the event and now is a really good hint as what the question is asking. So as soon as after the MI, you can go into an acute heart failure, you can have some funny arrhythmias, you could go into shock or cardiac arrest. Hours to days sort of leads to your pericarditis, your acute mitral regurg, and then once you get through sort of weeks, the classic one is Dressler syndrome, which happens after an extended period, so about 4 or 6 weeks usually. And then once you only literally need to know like a sentence for each of these, don't get fixated. But yeah, PASSMED's really good for these. They have a good little bank of questions, and it's all about repetition with these ones. And yeah, there's a prognostic factor. So this came up with the GRACE score, the CALIP class. And then there is also poor prognostic factors. So if they develop heart failure following an MI, that's a poor sign. If they have peripheral vascular disease, if they have reduced systolic blood pressure, if they cardiac markers were very high to start with originally, and if they had a cardiac arrest. And then this is just a little thing for completeness about unstable angina. I couldn't find any questions on unstable angina, so I think that shows that like they're not going to ask it, but to just be able to differentiate the stable angina from unstable angina. Stable angina would occur whilst the person is exerting themselves. So if they've walked up the stairs, they've taken a walk to the local shop, and they're able to rest, and that pain goes away, that is stable angina. The unstable angina, the patient is sat in the bed with chest pain, they're not exerting themselves. And with those patients, they would present as chest pain, and with that we'd have to exclude ACS, so the NSTEMIs or the STEMIs, and then we could label it as an unstable angina. But whilst we're waiting for the biomarkers to come back, you do find a lot of these patients could end up being treated as an NSTEMI. But this is more just what you see on practice, in practice, not like exam style questions. And then with these patients, they'd end up being referred to cardiology, they'd have an echo, and they'd have angiography to assess their heart function and the function of the vessels. So these questions are taken from PASSMED with some slight changes to the details, so they're not exact copies. So if you want me to do these now, I don't know what time it is, 10 to. If people want to stay and do these, that's up to them, or you feel free to go, I don't mind. What's everyone think?
Hi, so give a thumbs up if you're okay with staying.
Oh, what did you say, sorry?
No, I'm just telling everyone in the chat.
Oh, okay.
Okay.
Sorry, I'm staring at the chat. Do you have to give all NSTEMI patients with
Yeah, I think most people are okay with it. You can carry on.
Okay, I'll go through these and then I'll answer any questions afterwards. So does anyone want to answer this question? Or you can have a think. and write down what you would do, but you don't feel like you have to pop it in the chat if you don't want to. Okay, hopefully you've all had time to read that. I think I've put. So I don't know if that ECG was a bit small to see, but that lady had a left bundle branch block going on. So you can see V1, V2, this widen. So a new left bundle branch block, when you've compared it to an old ECG with chest pain, would be, she's having an MI, she's having a STEMI, so she's going to go for PCI. Does that make sense? Feel free to say if not. Yes, thank you. Okay. 66-year-old man is admitted with central crushing chest pain in the ED. An ECG is taken, which shows ST elevation. His only past medical history is hypertension, which he takes Rampril, aspirin, simvastatin. What is the optimum management of this patient? So this is a PASSMED style question. So you've got the risk factors: older, male. Then you've got your central crushing chest pain. So you're thinking already ACS. You've got your ECG that's been taken, and then it's telling you where the ST elevation is rather than giving you the image itself. And then you've got another risk factor here of his hypertension. So which one do we think? Yeah, perfect. The last one. So we can rule the first three out because we know he's having an STEMI. So he's definitely going to be having, he's definitely going to be having PCI. And then we give everyone aspirin, and the fact that first question, that answer doesn't have aspirin in, I would ignore that one first straight away. So aspirin, ticagrelor, IV heparin. And PCI is, I'm sure you all know, the gold standard for treatment for ST elevation MI. And then all patients would have 300 milligrams of aspirin. He's got nothing to say he can't have aspirin there, so you would have presumed he'd had aspirin. Okay, I think I've done a bigger version of this one, yeah. So this is another classic PASSMED question. Okay, that's the ECG. And then the question is, rather than asking what's happening in the ECG, the way finals questions can work is that you've got to pick up what's happening and then know what's then the next step. So it's not the, I've identified this and that is the answer, it's the step after that. So for this question, as an example, you've got to look at the ECG, pick up what the abnormality is, and then what is the most appropriate action. So does anyone want to say what they thought the ECG showed first? And if you can identify that, that will help you select your answer. Don't want to put anything, so we're going to go next. Okay, anyone want to go with what the answer is then? Oh no, don't worry. So with this one, this lady has hyperacute T waves. So if you looked back here, these T waves we don't have an old ECG to compare to, but these are large T waves. So they are indicative of a MI. They could be the first thing you'd see. So this could be 10 minutes before she could have the ECG, and then within 10 minutes she could have ST elevation showing. So you're catching it before that ST elevation has developed. So when we're talking about the development of STEMIs on ECGs, that would be the first thing you could end up seeing. So it's these T waves. That's where they're really obvious. And then I just put a little summary table here of therapeutic agents that you'll come across in ACS treatment. I'm not going to go through them. You can read those at a later date because it's just me reading off. But yeah, that's everything. Then my references. I really liked AMBOSS. I thought that was really helpful with finals revision because it's really broken down very well. You don't need to sign up for it. Just Google whatever condition, so ACS and then AMBOSS, and gives you an overview. Really, really good. PASSMED Brill. Life in the Fast Lane, which I got all the ECGs from. Pulse Notes is also a really good website for sort of breaking down each condition really, really, really clearly, methodically. And then BNF treatment summaries, although they sometimes can be a bit confusing, and RChem learning for ACS. What is a PCI window? So if you've already, sorry, what is the PCI window? So time allowed. So it's all about aiming to get it done within less than 90 minutes for a STEMI. Is that what you mean? Yeah. And then if they were having NSTEMIs, they could potentially end up with a PCI, but you definitely get them some sort of angiography, depending how high risk they are within certain time frames. Is that okay?
So when is the next student finals lesson? So the next one's going to be on Thursday. It will be close to the time. If you have the newsletter, signed up, there's a newsletter that comes out. Also, if you could fill in the SurveyMonkey to get access to the site as well, it's very useful. And then there's some other questions, Olivia, if you want me to read for you.
Sorry, so I'm looking. I'm going to move the screen.
It's okay. Asked what kind of intervention do high-risk NSTEMI patients need within 24 hours?
Oh, sorry, what was that? It cut off.
What kind of intervention do high-risk NSTEMI patients need within 24 hours? Is it PCI? So
they'd probably have at least an angiography, and then if they were deemed really high risk, so they were really, really sick, like the super high risk, like the cardiac arrest and stuff, they'd end up going for PCI rather than angiography. But basically they are at risk of having a STEMI at some point, so you want to check out the vessels, and you can look at that through angiography.
Okay.
Does that make sense?
Yeah. Another question is, do you give all NSTEMI patients heparin?
NSTEMI patients heparin? I think so. Yes, because they're at risk of getting clots. So let's go back to the very first. Feel free to correct me, but okay. Here we go. So you don't want, they basically, if you've got an NSTEMI, you've already got some coronary artery disease going on. You don't want that to develop into a STEMI, so you want to keep the blood thin, and you don't want to clog up the arteries. So a way of reducing that risk is to thin the blood down. So I would have thought, yes, you give everyone heparin.
Okay. And then someone's asked, is heparin part of the MOANA acronym? Okay, or is it a separate thing?
No. MOANA is like, that was higher up. Here we go. So I wouldn't get bogged down on the heparin stuff. Your big thing is your morphine, your oxygen, your aspirin, your nitrates, and your antiemetic. That is what you're going to do straight away. Your heparin is like the minute stuff afterwards, and it will depend on like what they're given by which doctor. Like someone would give you heparin, some people would get low molecular weight, some people would get fondaparinux. It's all like personal preference and things, and like based on like the clinical picture. But the thing that will be the same for every person is morphine, oxygen, aspirin, nitrates, antiemetics. So if you're going to take anything away, take that bit.
Okay. And finally, I have a question in regards to the ECG with the tombstoning. How would you differentiate? Like, is there particular ECGs that they present with, or is it like, you know, pericarditis is very like varied? It's like everywhere. Is there a difference?
So the easiest way to do that is to probably compare them for like they look different. Let's see if I can find something. Right, I'll stop sharing. Put me on the spot. I'm trying to find a good ECG to show you the difference. Okay. So I'm going to get two. I'll quickly paste them on. Sorry. Oh no, I've lost Zoom. Okay, so this on your left is tombstoning. So you can see the up and the down. Pericarditis is like the slopiness. Does that make more sense when you've got them side by side?
Yes, it does. Thank you.
Whoever asked that question. Any other questions?
No, I don't think there's any other questions. Okay.
And if it was too much, if it was all over going up over the top of your head, please let me know in the feedback and I will adjust for other sessions. And I hope it hasn't stressed anyone out for finals because you've got loads of time. You're really ahead even by attending this today. So please don't panic about having watched this at all. You'll all be fab.
Thank you very much, everyone. We'll see you in the next session. Hopefully you enjoyed it. And as I said, please fill in the feedback forms so you can get access to the slides.
Thank you. Oh, you're welcome. I hope it's okay.